Hello, got a patient, initials STS. He's a 47-year-old Caucasian male with past medical history significant for chronic kidney disease and ETOH cirrhosis. On 3/18/2016, he had an OLT and orthotopic liver transplant. His postoperative course has been complicated by an intra-abdominal hematoma. Status post and exploratory lap on 4/7/2016. With addition to that, he had acute cellular rejection. He was admitted on 4/17 to 4/28. He received steroids, thymoglobulin, an IVIG, intravenous immunoglobulin, and TPE times 4, which is a therapeutic plasma exchange. And also confirmed by biopsy, he was also given a CMV hepatitis cytomegalovirus. So he was on ganciclovir and currently on Valside. He was treated for orthostatic hypotension and acute kidney injury on top of his chronic kidney disease. So reportedly he was at home this week, having some decreased appetite, lethargy, weakness, fatigue, decreased urine output, and increased edema that he noticed to the bilateral lower extremities. He visited the clinic this morning and creatinine was increased 4.8 from 1.96 from his last lab results, which is concerning for worsening acute kidney injury on top of his chronic kidney disease and possible HRS or hepatorenal syndrome. He was admitted for further management. Upon admission, patient is alert and wanted with no acute distress. Appeared to have some orthostatic hypotension again with a systolic BP in 70s to 80s, for which he received 1 liter of 5% albumin. Review systems. General, no fever, no chills. It did have some excessive weight gain. HENT, no changes in vision, taste, hearing, or smell. Respiratory, no shortness of breath, no cough, no hemoptysis. CV, no chest pain, no palpitations. GI, no nausea, no vomiting, no abdominal pain, no upper or lower GI bleeding. GU, no dysuria, no hematuria. Skin, no skin lesions or anything like that. Skin is intact. Extremities does have some edema to the lower extremities and a little on the upper extremities. Neuro, no paralysis, seizures, anything like that. Hematology is easily bruising. Endo, he's got cold intolerance. Psych, no visual auditory hallucinations, and vascular, no claudication. Health status, allergies, he stated he's allergic to adhesive tape and spironolactone. The reactions were not documented or related by the patient. Current medications, he's on Cellcept 500 milligrams, which is 2 tabs of 250, so 250 milligrams POBID, Cipro 250, Q24, Colace 100 milligrams, 1 cap BID, Flomax 0.4 oral capsule, 1 cap daily, Prograf 1 milligram oral capsule, POQ 12 hours, Valsite 450 milligrams, 1 cap daily, vitamin B12 500 mics, 1 tab daily, albuterol inhalation, 2.5 milligram, 3 milliliter inhalation, Q6, aspirin 81 milligram, enteric coated PO daily, fluconazole 200 milligram, tablet PO daily, folic acid 0.4 tab PO daily, pantoprazole 40 milligrams, enteric coated tablet daily, pentamidine 300 inhalation powder daily, prednisone 5 oral tablet. I was actually 30 milligrams. You take 6 tabs of this PO daily, and ursodiol 300 milligram oral tablet, actually 2 tabs PID, so a total of 600 milligrams. Problem list: alcoholic or ETOH, hepatitis, ascites, bleeding esophageal varices, cirrhosis, liver transplanted, chronic hemolytic anemia, immunosuppressive management encounter following liver transplant, hyperbilirubinemia, acute kidney injury, and MRSA. Past medical history: ascites, that it's active, active medical history, ascites, chronic hemolytic anemia, and alcoholic cirrhosis. Family history, just so that they had arrhythmias, both mother and father. And procedure history, surgical history is liver transplant, of course, and the hemorrhoidectomy. Social history, he is an alcoholic. He will drink daily. Started at age 16. He stated that his last use was on the 10/15/2015. Substance abuse, prescription medications, PO pain meds, Dilaudid. He said his last use was on 10/15/2015, and tobacco, said he was never a smoker. Vital signs and measurements. Axillary temperature on arrival 97.6, heart rate 86, respiratory rate elevated 27, systolic BP 105, diastolic 67, 100% on room air. General alert and oriented, no acute distress. H&T normal, cephalic, neck supple. Respiratory room air and decreased breath sounds upon auscultation on the left lower lobe. The right side had better breathing sounds than the left. Cardiovascular normal rate, normal rhythm, no murmur, no normal peripheral perfusion, but bilateral lower extremity edema. GI soft non-tender, it is distended with ascites. Musculocskeletal normal range of motion, normal strength. Integumentary warm, intact, cool. Skin does appear jaundiced. And neurologic is alert, knowing with no facial deficit. Majority of the labs were within normal limits. WBCs were 9.1. Labs that were off were hemoglobin 8.6, hematocrit 24.8, platelets low 122, mag 1.6, phosphorus 4.7, PT 16.0, and INR 1.25. Impression and plan assessment. Of course, ETOH cirrhosis, status post OLT on 318 with acute cellular rejection. CMV hepatitis, ascites, loose stools, acute kidney injury on chronic kidney disease concerning for hepatorenal syndrome, electrolyte abnormalities, hypotension concerning for infection or possible sepsis, recurrent right pleural effusion, and malnutrition. Planned neuro-PRN, Dilaudid and Narcos for pain control, CV continued fluid resuscitation with albumin, pulmonary encouragement incentive spirometry. Consider possible thoracentesis if patient becomes short of breath for recurrent pleural effusion. GI, encourage regular diet with oral supplements. We'll place a small bowel feeding tube and start tube feeds for malnutrition. GU, Foley for strict INOs. Hepatology, immunosuppression for transplant team. Continue prednisone, and we're going to contact hepatology. Renal, start scheduled albumin and D5NS at 100 cc's an hour for rehydration. Renal ultrasound, start octreotide drip, and consult renal team. Infectious disease, blood and urine cultures are still pending. Plan for possible diagnostic paracentesis. PTOT, of course, will get him up out of bed. Ambulation, and at this position he is placed in ICU status. That's H&P. It's Ben Andrews. Thank you so much. Bye.